from wherever you are dialing from. Welcome to our second African Cancer Research and Control ECHO program. For this month of February, we'll be looking at pediatric oncology. Our topic is Uniting for Every Child, Strengthening Childhood Cancer in Africa. Today, we will have a case presentation and a didactic presentation. We have Professor Nindu and also Dr. Trish, who will be sharing. You're all welcome. So let us give a few minutes for others to join. And then after that, we'll have Professor Gita Naidu, who would start with the didactic session. So we are going to give 2 minutes for everybody to dial in and before we start the session. Thank you. Okay. So let me have the honor of introducing our first speaker, Professor Gita Naidu. She is a pediatric oncologist and also a global health leader. Currently, she's serving as the Director of Pediatric Oncology for Sub-Saharan Africa at St. Jude Children's Research Hospital. She has held senior clinical and academic leadership roles in South Africa, including clinical head of pediatric oncology at the Chris Hani Baragans Academic Hospital and academic head of pediatric oncology at the University of the Witwatersrand. Her training spans pediatrics, pediatric oncology, infectious diseases in immunocompromised children, health sciences researches, quality improvement, and implementation science. Professor Naidu plays a key advisor, including membership on the South African Ministerial Advisory Committee on Cancer Control and leadership within the International Society of Pediatric Oncology. Her work focuses on strengthening childhood cancer care across Africa through equitable partnership, capacity building, and locally led measurable improvements in care delivery. Welcome, Professor.
Thank you very much, and thank you very much for inviting me to talk about my new role at St. Jude. I'm going to share my slides now.
Let me unmute you, Prof. I think there was a challenge. Yeah, go ahead, please.
Let me just go back to my, first slide. Okay. Hi, can everyone hear me?
Yes, loud and clear.
Okay. Okay, so I've taken over the role as the Regional Hub Director in Sub-Saharan Africa for St. Jude. And so some of you, I'm not so sure how many of you are pediatric oncologists on the call, but St. Jude is in Memphis in the USA. And I'm going to give you a little bit of history a little bit later on how they got to the hubs. So really my role is I want to coordinate, strengthen, and expand pediatric oncology service across the multiple countries. But I also want to bring into my role the knowledge that our area is marked by political tensions, a lot of historical mistrust for what has happened, with the HIV program before that, but also that we have linguistic diversity on the continent, and many countries face economic fragility at the moment. And I really think my role requires more than just technical expertise. Yes, I have been a pediatric oncologist for 30 years, but now it is how do I look at our continent and how do I try to improve through St. Jude's what we can do for children with cancer. And I think it's important that we do not forget our history. And for me, this was really important. Coming in as an African and now working with a US-based organization and to work in Africa. And it's something I considered for a long time before I accepted the post. And I think what went through my mind as I thought about accepting this post was that we have strained political relationships. And me being a South African, we know with our bad history of apartheid, the poor relationships that we had in the region. And also, I really want to emphasize that I want to be a neutral facilitator. I want to make sure that St. Jude is seen as a partner rather than an external authority. And I think so many of the problems stem from that, where people were not seen taking us in Africa really as equal partners. Why does this matter? I think health initiatives fail because we appear to be aligned with certain political blocs. And for me, that's really important to know that we do not want to do that. We do not want to continue our colonial medicine or medical colonialism. And for me, this was really important. And this is why I speak about it today. And I want to emphasize that we really have to acknowledge and actively address our history in Africa with the States, but also with my own country, South Africa. And for me, the most important thing is that we have to have equitable partnerships. The local institutions must lead, and St. Jude's must support. And to me, this is really important that we emphasize capacity building over dependency, and we have to empower our local clinicians and everyone that works in the healthcare sector. There are many challenges that we face when we work in low resource settings. Maybe in South Africa, we are slightly better off, but actually we are also a low and middle income country. And for me, the challenges that I want to be cognizant of as I work in Africa is the unstable infrastructure, limited diagnostics, staff shortages, underfunded health systems, and also importantly, even in my own country, competing national priorities of HIV and TB and malnutrition, and in other African countries, malaria. So to me, it's really how do we strengthen the healthcare systems? And we have to do this by actually making sure that we do have national cancer care control plans focusing on pediatrics. And when we talk about the regional workforce capacity, it is everyone. To treat a child with cancer is not only the pediatric oncologists, as we know, it's the pathologist, the surgeon, the nurses, the pharmacist, the psychosocial support staff, the data managers, and also how to train people in fundraising, because so many of our patients require support. And to me, this is where the NGOs come in. And to me, finally, is how do we create within Africa centers of excellence? So the regional hubs, the first one that opened was in the Eastern Mediterranean region in March 25. Then the Sub-Saharan region has just opened. Well, actually, it was a little bit earlier. We opened in November. And the third one will be in Mexico. But there are other regions that are planned also for Southeast Asia, for South Asia. So there are other hubs coming across. And why do we have these hubs? So St. Jude's is a massive organization, and they have been working with partners across the globe. But what they feel is that they want the hubs to really take full control over what happens in these regions with their support. So it's really for network development, capacity building, and patient-centered care, for education, to improve education, and also to help support research in the local regions. So just to go through a little history, St. Jude's started in 1962, and it's only in about 20, then they had the twinning program between the 1990s and the 2000s. And as you can see, these were the twinning countries. And St. Jude's decided to move away from this idea of twinning countries, because it's almost like the country you twin with has to depend on you. And that's what they want to move away from, that it is not a relationship of dependence, but really is actual equal partnership. So sorry, the slide. Okay, so what they have done now, in each of the regions, we have Global Alliance partners. So you can see from this map how many hospitals have become global partners. And I apologize because this slide was from December 2025, and I didn't have a chance to update the members. We have more members now. I think in the medical institutions, there's about 42 already. These are signed up, and then in progress, few more. And also importantly, that we have foundation members. So you can see from this region that we have more and more countries who have joined the St. Jude Global Alliance. And one of the things that we have done is we have done a profile analysis. I did that in South Africa, and it was really a very deep and in-depth look at what different categories, our workforce, our diagnostics, our therapeutics, our supportive care, patient outcomes. What about support for the family? So we have done that. And the important thing about this is that institutions can use this to negotiate with their health, with their hospitals, but also their ministries of health, to show them this is what we lack, this is what we need. So this profile is an ongoing. Currently, we are working in the French-speaking regions, and there's about 12 countries between May and June who will have their profile analysis completed. So, oh yes, this is the slide with the GFAOP countries. So to me, the important thing about working with the information we get from the profile is how do we, besides working with our governments, how do we leverage this to work with the WHO GICC? For those of you who are not pediatric oncologists on the meeting, the Global Initiative for Childhood Cancer is actually a project that was set up by St. Jude's and the WHO in 2018. And the aim of this is to improve overall survival for childhood cancer, actually in low and middle income countries, to 60% by 2030. So we know that 80% of the world's children with cancer resides in low and middle income countries. And unfortunately, survival rates are as low as 20%. And only 20% of the world's children with cancer lives in high-income countries, and they have an unbelievable 80% survival. So I think this is very discrepant, and this is one of the reasons why the WHO and St. Jude set up the GICC. So it's really how do we use the information from the profile to try to improve our outcomes for children with cancer. So so there are many transversal programs and tools at St. Jude's. And for me, the one that I used in my former hospital was the registry. It's called the SJK's registry. And as you can see here, many countries around the world are using this registry, but as you can see, this information is from November last year, and many more countries have added been added to using the registry. The registry is an absolutely fantastic tool because it gives you such an in-depth understanding of your patients. When did they come? When did they start treatment? How long did it take to get the diagnosis? Did they abandon treatment? Why did they abandon treatment? When did they go into remission? What were their toxicities? What was the outcome? So to me, this registry, which we are also using in my country, is a fantastic tool. And as we can see here, Sub-Saharan Africa has really experienced a real increase in the cumulative accrual of patients. So I'm really glad to share this with you, that many African countries are now using the SJK's registry. In addition, every Friday we have a tumor board. And these are the numbers from last year. You can see how many countries presented on this tumor board. And we had 3 countries from Kenya. So we upload the patients, and St. Jude's invites people who they think may be experts in the field, but also to focus on local experts, our surgeons, our pathologists, and to get them for their input on these interesting or complicated or difficult patients. So I encourage you to share your patients and discuss them on this weekly tumor board that we have. The next thing is that we decided that we wanted to, one of the things that St. Jude's does is guideline development. And we looked at guidelines here for, well, there were 2 groups. One was the Sub-Saharan group, where 14 institutes participated in the guideline development, and then we had one for South Africa. And this was a complex process, how we went through it. It was with St. Jude's plus the University of South Florida, their methodology department, and we worked through the whole guideline development. The Sub-Saharan African group has already published their paper in Lancet Oncology, and the South African paper is just been accepted in the South African Medical Journal. So to me, this was really important because until now, we were using guidelines that were developed by ITSA in the States, or the German guidelines, or the British guidelines. But these guidelines didn't take into consideration that we may have limited testing. Our blood cultures may come a little bit later than what they are in other countries. The antibiotics that we have in Africa may not be the same. Also, those guidelines don't talk about the child with HIV infection or with TB or with malnutrition. So for me, this was something really important. But now that we have that guideline, the next step is how do we implement that guideline? So many people across Africa are involved in implementation science workshops with the Institute of Healthcare Improvement to work out how to implement the guidelines. And part of that project is a fever reg, which is the Global Fever Registry. So to me, this is also something important, and you can see which African countries, Kenya, South Africa, Zambia, and Zimbabwe are part of this project. The next thing that we did that was quite important, we evaluated the pediatric academic training, EPAT, across regions in 21 different hospitals in South Africa. In Africa, we had many workshops to evaluate our training. A publication came of that. And so this was something that was really important because now we are working on how to improve our training and evaluation for pediatric oncology across the continent. The next important project that we are working on is the Global Palliative Care. And there are different projects. There's ADAPT, there's PROTECT, there's the Global Comfort Promise. And so even with those, there are now implementation and improvement science projects that are occurring across the continent. So as you can see, South Africa has been involved in many of them because I truly believe that these projects are really good and they're making a difference to our patients. And the one thing I want to share with you is that a lot of these projects, we've included our nurses. And our nurses previously have had no exposure to research or to writing papers or participating at conferences. And we've just had one of our nurses, quite a junior nurse, who participated in one of the palliative care projects, who presented at an international conference. I think it's not only empowering us as doctors, improving the lives of our patients, but also empowering those that we work with. So the other important project that is happening at St. Jude's is the ARIA guideline. So this is something that is a massive global project, and there are people from basically all over the world, many Kenyans, many Africans that I know of, who are part of the ARIA project. So it's basically about resource adapted management. And so it's taking protocols, and we have people from all over the world, and they talk about what diagnostics do they have, what supportive care do they have, how quickly can they get platelets if they need it, what antibiotics are available, how easy is it to administer, to use a guideline and to stick to this guideline. So what the ARIA guideline is really is about resource adapted management, and it's divided into the 5 World Bank categories. It is an app. If you want to use it in your country, you put in your details, and it tells you for that particular disease, which category you are. It gives you the guideline. You put in the height of the child, the weight of the child. You can print it and put it into your patient's file. It will remind you need to do a CT scan on this day. You have to, based on that CT scan result, what is the next part of the treatment. So the ARIA guideline is not only about guidelines on how to treat cancer. It's also about, they have sections on supportive care, on, for example, methotrexate toxicity. How do you deal with that? Febrile neutropenia, nausea and vomiting. There's also on palliative care. So it's a really extensive guideline. At the moment, it's still in progress. At the moment, there's 3 treatment guidelines out, but many will soon be coming. I'm working on the ALL. We are hoping to have that done in the next few months. But yeah, so if you are interested, please look at this ARIA guideline development at St. Jude. The other important thing is that they have a policies and health systems department. And what this does, this department, together with the WHO, using the Cure-All framework of the Global Initiative for Childhood Cancer, they train on how to write a national cancer care plan. So some have adults on it, some have for children. When we did it in South Africa, we included adolescents and young adults on our plan. So this is also something important for countries who do not have an NCCP, for how to, it's a 7-month course with WHO and St. Jude's, and then you will be able to, and also they encourage that you include people from your Department of Health. So whatever you write in your plan, it is endorsed by your government. The other important part is global critical care. And you can see this is based on the Pew system, and many African countries are participating. These in purple are who were the pilot sites for the Pew's project, and the other countries have been invited to participate as well. So for me, this is really important. This next one, it's the global platform for access to childhood cancer medicines. So St. Jude's has committed a huge budget to allow certain countries to be able to get free medicine. So it's around the globe. At the moment, there are 12 countries. So our first country in Africa was Zambia. And up next is Ghana and Senegal. And there will be calls for more countries to be added. And I think this is an absolutely fantastic program that countries can get free access to treatment. The next one is St. Jude's offers a master's program. And as you can see, every year, more and more applicants from Sub-Saharan Africa have participated in this project. And for me, it's really great because after you've done your master's, if your project was a good project, you will get 2 years of financial support to carry out your project in your country. So to me, these are the countries so far that have participated, and we're hoping every year that people from different regions in Africa will apply for this program. The next important one is the Global Hematology Program. And we know that the most number of children or people with sickle cell disease are in Africa. So this is a new program from St. Jude's, and we are hoping to work across the different countries to improve sickle cell disease outcomes. So this is just a map to show, of course, we all know this, that most of the world's people with sickle cell disease are in Africa. More than 75% in sub-Saharan Africa. So this is it's a global initiative to through screening to screen 90% of newborns, to treat 90% of affected children with essential care, and to achieve a 90% survival at age 5. The next important part of the St. Jude program is ALSAC. ALSAC is really their fundraising component, and it is what allows St. Jude's to function as they do, but they have a huge footprint globally, but also in Africa. Many African countries are part of the ALSAC, as you can see in Zambia, in Zimbabwe, in Ghana, and they've started something new on the education, which I think is so important. They're training local people on fundraising, and then they allow them and follow them and track them through, every few months. How you're doing, what have you been able to fundraise, who in your region have you reached out to? So I think this is as important as it is to have the ALSAC, but to teach people locally on how to do fundraising. It's such an important concept to me. Sorry, I don't want this. So my role really is to engage with sites, to visit and understand the local context, the priorities and challenges, and of course to align with the core principles of St. Jude Global. And it is really, and I've started doing this, engaging with local government and senior hospital management on how we can support pediatric oncology services. And really, that we have to remember that even though communicable diseases are a big problem in South Africa, that we cannot not focus on the non-communicable diseases, and to focus on training of the workforce, to see how we can improve the global platform for access to childhood cancer medicines in Africa. And a new project that has started is the access to radiation oncology. And for me, how do we sustain whatever we start in Africa? And that, for me, as I said right from the beginning, it has to be a relationship based on trust. And for me, I want to end with the Nelson Mandela quote: "History will judge us by the difference we make in the everyday lives of our children." Thank you.
Thank you very much, Professor Naidu, for that insightful and grounding perspectives on the strengthening of pediatric oncology care across the region. Building on those themes of equity, system strengthening, and sustaining impact, our next speaker is Dr. Trish Scanlan. Although she's unable to join us live today as she's traveling, we are very pleased to share her recorded presentation. Dr. Trish is a pediatric oncologist who has worked in Tanzania for nearly 2 decades and has played a pivotal role in strengthening childhood cancer care nationally. She's a volunteer pediatric oncologist at the Muhimbili National Hospital, the CEO of Tumaini la Maisha Children Cancer Charity, and a key leader in the establishment of the Tanzania National Children Cancer Network. We are also joined by Ms. Nilinian, who she's the Chief Operating Officer for Tumaini la Maisha Tanzania, who is here on behalf of Dr. Trish and will be available for our Q&A sessions. I would also like to remind all participants, kindly share your questions in the chat and we will go back to them during the discussion. Thank you. ECHO team, can you please play the recording of Dr. Trish? Thank you.
Hi everyone, my name is Trish Scanlon. I am a children's cancer specialist.
And it's not very calm. I'll just beg on you that you try to follow up with a later time.
Apologies, let me share.
Yeah, so as we were waiting for the connection, if anybody has any question for Professor Naidu, you are welcome to share your questions.
Hi everyone, my name is Trish Scanlon. I am a children's cancer specialist who's been in Tanzania for 20 years. I'm really sorry I'm not there in person today, but I hope this recording will give you a flavour of what we're doing in Tanzania. I'm very grateful for the opportunity to talk about our work in Tanzania, which is summed up by the phrase Tupo Pamoja, which means we are together. And collaboration, I think, is the key to success of children's cancer services across the world. So one of the things that I think is the real success and a real argument for concentrating on children's cancer services, or cancer services, I guess, in general, is that unlike many other types of services, you cannot have a functioning cancer service unless you have every part of the health service working. And so if you do have a functioning cancer service, then your supply chains are working, your nurses are strong, you have good surgeons, radiology, pathology, in general, every part of the health service is working. So in order to set a cancer service up, you have to support colleagues right across the hospital and the health service. So just to give you a flavour of where it all began, I arrived in Tanzania in 2005, and at that time there was one children's cancer ward based in Dar es Salaam in the Ocean Road Cancer Institute, which was run by one doctor, and they had reliable chemotherapy for one condition, Burkitt's lymphoma. There were 3 nurses. There was indeed strong political will at the time, which was really powerful and helpful, and that meant that children could come without fear. But the problem was that there wasn't reliable medication for consistently throughout the year. So I looked at the figures of new cases in 2005. There were 133 who came in the hospital at the time. And as you can see, the only bar, and these were looked at very early in 2006, so the only bar that had any chance of survival was this small bar here, which was 12% disease-free, with very, very early follow-up. So, and this was, just over 100 kids, which was a very small percentage of what was out there. So essentially the survival was close to 0. At the time, there was this one ward which had 17 beds, and initially it was 17 beds and 17 kids. But as things progressed and we improved the service collectively, more and more children came. And on our busiest day in Ocean Road, we had 90 children in those 17 beds. So yeah, it became chaotic. One thing that was improved, so that overall survival of less than 10% excluded children with Burkitt lymphoma, because already they had made huge progress with Burkitt lymphoma in the first 3 years that the ward was open. And as you can see there, the children had a complete response of 75% in Ocean Road. Now, as you can see in the graph there, it's lower, but that's because it was a multi-center study and Ocean Road was doing better than other sites. So that for me was a proof of concept that, you know, things could change very rapidly and the right people were on the ground. They just needed the right resources and support. So I'm going to flash forward 20 years now. So where are we now? So our survival rates are still, they're much, much better, but they're still only at 50%, and we do need to work on that. But we now have, instead of one site, we have 21 sites, and we want more. We say 30 plus, we'd love 100 sites in our network. And I'll explain why in a minute. It sounds a little bit bonkers, but it works. And our children's numbers, as I said, have increased from 133 in 2005 to 1,102 in 2024. So an enormous number of new sites and an enormous number of new children. So how did we achieve this? So the first thing was setting up our National Children's Cancer Network. And as you can see there, the coloured parts of the map are parts of the map that have a site. They're not all treatment sites. So level 3 and level 2 are treatment sites. ORCI, which is the Ocean Road Cancer Institute, is a unique site because it's our radiotherapy site for children. Level 1 sites, which are the pink sites, are stabilize and transfer, and then in reverse doing the follow-up and palliative care. And these are essential. So we have 9 treatment sites, including Ocean Road, and the remainder of the sites that we collaborate with are those level 1 sites. And one of the big successes has obviously been led by offering chemotherapy to the children. So we provide, Tumaini La Maisha is a children's cancer charity set up to support childhood cancer services across Tanzania, and we provide free chemotherapy to all children across this network. And of course, nothing is free, someone has to pay, but is it cost effective? Well, the cost of the chemotherapy is equivalent to approximately 11 children in Europe, in Finland specifically, because this has been a report published, receiving leukemia care. So we do think, yes, over 1,000 children receiving care is cost effective. So we even did a 5-year assessment of where we had gone from 2020 to 2025. And as you can see, our numbers are really improving, our partner sites, and also the children's access to the site. We aim to have at least 95% of children with a 4-hour access, and we're along that road. And what other improvements have we done? Well, we have built things. We've built children's cancer ward, we've built hostel, we've built PICU, and we've built a neonatal intensive care unit, which is sort of a separate project that was just requested by the hospital. So we try and help the hospitals where we can, and that's at the hub in Dar es Salaam in Muhimbili National Hospital. But then nationally, we support radiology and surgical services. So if children need a scan or a surgery and they can't afford it, we will pay for it, and we being Tumaini La Maisha. And we also transport samples and chemo from the hub in Dar es Salaam to our 8 collaboration sites around the country. And the same for the samples. They go to one of 3 centres who are processing our oncology samples locally. And then in our lab services, there are 3 hospitals now who have leukemia diagnostics and also pathology diagnostics, so flow cytometry and immunohistochemistry. And then we also send samples out for metabolite screening for neuroblastoma, and we can also do BCR-ABL for CML at multiple sites. And this is how we do it. So either we use DHL or we use the bus network, and to move children. We have to pay the bus, we use the mobile money network, and so bus to be closer to home. What else have we done? Well, we have set up medical training. So we wrote, Tumaini La Maisha wrote an MSc, which is now a fellowship in pediatric hematology oncology, and it is being run out of the Muhimbili University for Health and Allied Sciences. We also have nurse training courses, and we also have lots of short courses. And as you see there, for many of our different colleagues, we try and support as well. We also have an electronic medical record system, which is built by TLM. It is live in 8 hospitals since 2025 and has comprehensive data from all of those 8 hospitals on children's cancer. It collects patient data by site. You can pool the data nationally, and the data can move between hospitals. So if a child is moved from one to another, then you just add the new hospital number, and that unlocks the data for that child's previous hospital stay. And it collects all, cancer-specific information, which is very helpful for a child, for an institution, and also for the government, and also for donors. We also have a chemotherapy prescribing tool. Now, we only have this in one site because it's still Excel-based. I know that there is the ARIA program, so we've kind of paused improving on it, but our Excel-based program has certainly helped us reduce chemotherapy prescribing errors. And in terms of psychosocial support, well, at Muhimbili, we provide lots of nutrition support. We make sure every child gets 3 meals a day, and every child gets extra porridge and 2 smoothies that we make fresh every day. And then we also have a therapeutic program and protein balls, which are prescribed by our nutritionists. And we have nutritionists at 3 sites, 3 largest sites in Tanzania. We also pay for health insurance cards for the children, and that again allows them, even when they leave our site, if our site is providing care for free, some of them do, some of them don't, that they can go to other sites with their cards, and that helps them. We also transport the patients because we found that a lot of children were waiting. They were the treating or the where they presented first, realized the child had cancer, but then they were waiting months to raise the money to buy the bus fare. So they just contact us now, and we will send them money through the mobile phone network. And we also do that for follow-up, which is specifically helpful for children with on maintenance leukemia treatment, because they have to come so regularly. We also have lots of education programs. So we have 2 teachers who are municipal teachers, and this has allowed children to continue with their studies and even do their exams on the ward, and this has really helped. We have 2 clowns, and we also have 2 play staff. So we have 4 play therapy kind of type professionals, and they bring a lot of joy and laughter and color to the children's days, which I think is really important. We built a hostel, as I said, and children can stay if they live far from home. So between cycles of treatment, the children can stay in the hostel, and there's lots of kind of fun activities happening there. And families also get a welcome pack of items, because a lot of families come with very little. And we have a skills room for the parents, which allows them to learn various different skills. And if they really engage with the program, we actually give them a sewing machine to go home with. We've written a parent's handbook, which describes, all that they might need to know about cancer, or about their stay on the ward, or about any of the side effects. And we find it very, very helpful. And we talk
Hello. It seems we lost our audio, but let us proceed. I think once we have that back on, we can continue. So I saw there was one question in the chat. It was from Peter Ngungi, and it was to Professor Naidu. The question was asking, for St. Jude's, how can nurses contribute to the goal in palliative care from the institutions they generally are working in? Professor Naidu, I'm not sure. Yes.
Okay, I couldn't unmute myself.
Oh, sorry about
Yes,
that.
thank you very much for that question. So, as I've said, St. Jude's offers these packages for palliative care, and there are different packages. So, if a hospital is interested in in training their staff, be it social workers, nurses, or young doctors, they could contact me and we could arrange a meeting with St. Jude's to see how we train the group of people who may be interested in learning about palliative care.
Thank you. I hope, Peter, that okay. So yes, thank you, Peter, for that response. So maybe another question I can ask Professor Naidu. As we know, we don't have a lot of trained pediatric oncologists. With the efforts with St. Jude, how do we ensure that we spread the pediatric oncology care? And maybe in terms of looking at task shifting, using other professionals, or some sort of training that can build capacities in these centers. Can you please unmute Professor Naidu?
Hello? Yeah, sorry. What was sorry, can you just repeat that question? I didn't hear it. I was trying to unmute myself.
Sorry about that. Yeah, I was asking, as in the region, we know we don't have a lot of trained pediatric oncologists. So what efforts are being done with the help of St. Jude so that we can help build capacity, maybe even task shifting so that we have basic pediatric oncology care in different areas?
Yeah, so St. Jude's has started for Sub-Saharan Africa an observership program that people can apply for observership to go to a different place if they do not have pediatric oncology services in their hospital. Also, starting in June, you could apply for a fellowship program where you can have training. And then, of course, as I said, there's the Global Platform for Access to Childhood Cancer Medicines that, as part of your country, you can apply for that to do the profile exercise in different regions, different hospitals, and to use that to leverage how you can become a GICC focus country, how you could then apply for medicines, radiation oncology. So there are many platforms that can be utilized to try to improve the services that are being offered. So I'm very happy for people to contact me if they want to become Alliance members or they want to learn more about St. Jude.
Thank you very much. So I think now we'll go back to our ECHO team. I think they're ready to play the video.
Places where the children stay and just kids have fun. We are also the first organization that is collaborating with Make-A-Wish in the continent of Africa, and we're very proud of that. And we have we've done lots of wishes, but we need to ramp it up and have lots more. We also have an awareness campaign using the helpful early warning signs and various campaigns for retinoblastoma. We've done it kind of regionally and locally with all of our network sites, but we would like to do it nationally in the coming 5 years. But it's not just us And I think no institution could do everything on their own. So it's very important to acknowledge and to highlight the amazing work that our collaborators are also doing in Tanzania. So Global Hope, they are running the fellowship program for pediatric hematology oncology and have trained, I think 17, I think was the last number of locally trained specialists, which is fantastic, and not just Tanzanian, but East African. They're also helping with clinical care, providing staff and expertise. They are also involved in the diagnostic services, and they have managed to bring a new vendor for flow cytometry to Tanzania at a much better rate, and have opened that up for the rest of us to also participate in. So that's been really helpful to have that partnership. We also partner with hospitals in Ireland who have really done an awful lot over the last 20 years, setting up pathways for pathology diagnostics and then second look pathology now that we have it all locally available. Same for leukemia diagnostics and for neuroblastoma. IPAN is a charity that supports nutrition right across Tanzania, specifically oncology, so we're delighted with them. Serenox is it's a not-for-profit lab that has worked with Oxford and MUHAS to help with leukemia diagnostics and really complex research. ALSAC, I think everybody knows, and St. Jude's Global, everybody knows the work that they do, and we're very grateful to them for the support they give. And iCare is a small charity that's run by one of our colleagues, Kristen Schroeder, who spends half her time in Duke and half her time in Bugando Hospital, and she helps in multiple ways through that charity. And then the last thing is our clinical our collaborative research, and we have lots of very interesting research. The AI Real looked at a liquid knife circulating free DNA, comparing that to biopsies for lymphomas. TopCat is a randomized controlled trial looking at late stage retinoblastoma with a new combination of chemotherapy. Salama is looking at the whole exome sequencing of children with acute leukemia. Clever Charts is what we call our electronic medical record system, and we have an implementation program, which is kind of an audit study. We're also doing a chemo quality study with one of our German partners, and Niche is a microbiome study looking at acute leukemia patients' microbiome, and that's, again, all of these are with international partners, and without them, it would be a lot more tricky to do these things, so we're very grateful to them. So we put this all together, and this is the virtual toolkit that we offer to our partner sites around the country in varying degrees, so that they don't have to reinvent things. And the whole idea is, no matter where the child goes in to present for care, that the care will be standardized right across the country. They can move from a level 2 site, which can treat some things but not everything, up to a level 3 site, which treats everything, and obviously from a level 1 that just stabilizes and moves them along. But our plan is to reach every child. And as you can see here, if you go from 5 to 31 sites, green means it's covered. And if we got to 31 sites of targeted sites, you'll see that we would have 95% coverage. Now, it doesn't look like 95%, but that's because Tanzania has kept lots of its land just for animals. So we don't actually have to color in all the red parts to be everywhere. But we still have a ways to go to get to that point. And this is where we were in 2024. Sorry, I should have updated the slide. And as you can see, from 2005 to 2024, we've made huge progress, both in the number of kids presenting for care and the children who are cured, although that should be much, much higher. And we hope that will be in the coming years. The problem, though, with statistics is that you need to zoom out, because this is actually where we need to be, because we feel that we're probably only seeing between 25% to a third of children who are actually out there. And so we really need to get to more children, and that's why we want to build that network and have 100 level 1 sites, all of whom can feed into the level 2 and level 3 to get the children access and the care they need as soon as possible. So that is what we are doing. I'm very grateful that we have so many extraordinary collaborative partners, both local, the hospitals, the government, the parents and the staff themselves, and then our international partners who are helping as well. So thank you very much.
Thank you very much. So I also like to acknowledge that Pales Palesa Kwatale had shared a survey. Everybody, you can check on the link and fill the survey. It's looking at clinical trial coverage in Africa. So now we are welcoming our Q&A sessions. Please feel free to share your comments, your questions through the chats. And thank you very much for our presenters. Thank you for the great work that you're doing in improving pediatric oncology across the region. So maybe I can also ask another question to Professor Naidu. For the countries or centers that are considering opening pediatric oncology, maybe what are the key, maybe three things they need to concentrate on, which will give the maximum impact, and also maybe in terms of data collection to know how they're improving and how to improve their quality. What are the key things they should look at in that also?
I think the most important thing will be for those countries or hospitals that are planning to start a pediatric oncology service is the workforce, the diagnostics, and the therapeutics. So for me, the workforce, includes pharmacists, nurses, surgeons, pediatric oncologists, and how they get trained, and then to have the laboratory on board, and then to have access to treatment, and to have, of course, with that supportive care.
Thank you very much. So maybe Miss Lillian, are you unmuted? So Miss Lillian, she's the Chief Operating Officer for Tumaini la Maisha. So a question to Miss Lillian, maybe if you can share what has been most effective in helping expand Tumaini la Maisha when we look at the formed National Pediatric Oncology Network.
Thank you, Dr. Sarah. I'm here with also two doctors, Dr. Simon and Dr. Miraji, who will also add on to what I have to say. But initially what we're doing, we're looking at the cases which have been referred to Muhimbili National Hospital in terms of, for example, they look at the data where most of the kids are coming from in terms of the other government hospitals. So for example, if we find that most of the kids are maybe coming from Dodoma University Hospital, they're being referred to Muhimbili. And then we find that we're not in partnership with that hospital. So we start reaching out to them by saying that we've seen a number of cases that have been referred to Muhimbili from your hospital, and we are Tumaini la Maisha, and just explain what we do and how best we can partner. Thereafter, after we sent the initial communication, then we set up a meeting with them whereby we go there and explain more what this collaboration will involve. So once we agree on the terms and conditions, then we enter an agreement. So what we initially did is just to see the number of cases that are coming from which parts or which regions of the country. And the place where they have the most number of kids being referred, we start with that area first.
Thank you very much. So I think today we've learned a lot, looking at the work that St. Jude is doing, also Tumaini la Maisha, clearly showing the need of collaboration and expanding networks in order to improve access to and improving pediatric oncology in the region. So there was another question in the chat from Thomas Moses. He's working as a pharmacist, and he was rather asking how or what studies does he need if he wants to become a pediatric oncologist. So maybe Professor Naidu or maybe Lillian, you can share about training opportunities that could be open to Tommy, who is a pharmacist and has interest in pediatric oncology.
Thank you. Maybe I could start. The trainings do come up, but normally we start with hospitals that are in the NCCN, the collaboration, and we do have a WhatsApp working group for all the centers that have joined, whereby we share all the information about trainings that are available. and they can be available from Tumaini La Maisha or from Mbili or from our partners. So we always share in the WhatsApp groups. So every hospital that is in the network has a real-time access to all the trainings that are on offer. And yeah, that's at least what's happening here at Tumaini La Maisha. And maybe Dr. Miraji, if you have something to add on that. And I am not sure if that was my question, but that's what's happening from our ends here in Tumaini La Maisha.
Hi, can I come in?
Yes, please, Professor.
The way I understood it is that this was a question from a pharmacist who wanted to know how he could train to become a pediatric oncologist. Is
Yes.
that the question? Yeah.
Okay.
So you'll have to obviously first go to medical school to qualify as a doctor. And I don't know how it's done in other countries, but most countries in the world, then you'll have to become a pediatrician. And then as a subspecialty, you will have to train in pediatric oncology. I hope I'm answering the question.
Yes, I believe so. But so I hope, Tommy, we were able to answer your question, but also to take note, there are some fellowship observership programs that are available through St. Jude and through Tumaini La Maisha, so that you can come and get walk-on experiences, even as a pharmacist, because I believe in oncology care, all multidisciplinary are important. And I think those opportunities are also open and something to explore. I'm not seeing any more questions in the chat, so I will now welcome Dr. Sam Bunya to come and share his comments. Thank you.
All right, thank you very much, our moderator of the day, Sarah. So my name is Dr. Sam Bunya, the current steering committee chair of the Africa Cancer Research and Control ECHO program. And it's also wonderful to see this audience, quite a number who have joined in for this very important session. And also at the same time, very happy to see Professor Gita Naidu and also Dr. Trish Scanlan share their presentations, and also at the same time be able to provide a way forward for in terms of the theme uniting children with cancer in Africa. Thank you, Dr. Sarah, for your able moderation of the day, and also at the same time having this session be a success. The KENCO team, Kenya Network of Cancer Organizations, which is the hub of the Africa Cancer Research and Control ECHO program, we appreciate them as well for being able to have this session in place, and also the steering committee members. My final statement is basically to say that as we conclude this, today's session, we are reminded that transforming childhood cancer outcomes in sub-Saharan Africa is not the work of one institution, one country, or one program. It is a result of trust, partnership, and shared responsibility. And this is also alluded by Professor Gita Naidu's presentation, and also the work that St. Jude is actually doing in sub-Saharan Africa. And also we congratulate her for the position that she's in, and we look forward to working with her. Her presentation, however, highlighted more than expansion. It's demonstrated intentional strategic engagement across the region, from strengthening pediatric oncology systems in low resource settings. And this has also been shown, and also been shown through Dr. Trish's pre-recorded presentation, to embed services within national cancer control plans, to advancing workforce capacity through fellowships, registries, and guideline implementation. So we are witnessing tangible progress. And as as already mentioned, we have seen regional collaborations through weekly case discussions, and I think most of the countries are doing that across multiple countries. Implementation of evidence-based febrile neutropenia guidelines and the activation of FEVERAGE. Growth in global scholars from 13 sub-Saharan African countries, expansion of access to childhood cancer medicines, integration of palliative care, critical care tools, and resource-adapted management strategies. Ministries of Health engaging in structured cancer control planning, very important in terms of aligning with the WHO GICC framework. So what stands out most in this commitment is decolonizing global health, so to speak, ensuring that local institutions lead while global partners support. This is how sustainability is built, and this is how systems are strengthened, and looking at how survival improves at the same time. Not to forget that the Africa Cancer Research and Control ECHO platform, which we have been ongoing for a couple of years, plays a critical role in this ecosystem, and it allows us to share this expertise without borders, align research with practice, and build capacity equitably. Foster regional centers of excellence, and that has also been alluded by Professor Gita. And most importantly, ensure that every child with cancer, regardless of geography, has a fair chance at cure. So the work ahead remains significant. Infrastructure gaps, workforce shortages has been also highlighted, and competing health priorities persisting. But the momentum is real, the partnerships are strong, and the leadership is regional. And the commitment is unwavering at the same time. So let's continue to build these relationships based on trust, and also strengthen the systems rather than create dependency. And let us ensure policy translates into practice. And let us remain united based on the theme of this session in pursuit of equitable childhood cancer care across Africa. And we definitely thank all the presenters, country teams through KENCO, the Kenya Network of Cancer Organizations, as the hub of this ECHO program, ministries of health as well, partners, clinicians, researchers, and most of you are in this session, and also advocates who continue to move this vision forward. So together, we are not just discussing change, but also at the same time, we are looking at implementing it at the same time. Thank you very much. And over back to you, Sarah, as you also finalize this session.
Yes, thank you. So this will mark the end. Thank you all for attending, and of course, great thanks given to Professor Naidu and Dr. Trish for this insightful presentation, sharing the need for equity, in the need to improve pediatric oncology within the region. Thank you very much. So now we can welcome the KENCO team for house announcements as people are logging off concerning the next sessions in the next month. Thank you.
Thank you so much, Dr. Sarah. I'd like to invite Charles to speak. We are in a conference and will kindly Charles speak on behalf of KENCO. Thank you.
Thank you very much, Phoebe. Yeah, would like to thank our speakers for today. It was quite an informative session. So our next session will be held in March, the last day of March. So please look out for the topic and the details, which we'll be sharing fairly soon. So thank you very much, and wish you a good time.
Thank you. Bye.
Thank you. Goodbye, and everybody have a good day. Thank you very much.